Rheumatoid arthritis. Rheumatoid arthritis is a systemic autoimmune disorder characterized by chronic destructive inflammatory arthritis with systemic joint involvement that results in synovial hypertrophy and pannus formation, ultimately leading to erosion of adjacent cartilage, bone, and tendons. Risk factors include female gender, age 35 to 50, and HLA-DR4. Usually starts slowly, insidious over weeks and months and progress to 70%. It can come overnight acute but can be over week. Patient usually present insidious in onset of morning stiffness for more than 1 hour, which is painful, warm swelling of multiple small joints, wrist, MCP joints, ankle, knee, shoulders, hip, elbow for more than 6 weeks. Fever, fatigue, malaise, anorexia, weight loss may also be seen. In late cases, ulnar deviation of the finger is seen in the MCP joints and hypertrophy. Also presents with ligaments and tendon deformation, as for example, swan neck and botanier's deformity, vasculitis, atlantoaxial subluxation, intubation risk, and keratoconjunctivitis Zika. Initially, most patients notice stiffness of the joint, which seems more pronounced in the morning with some fatigue and pain. RA usually begins as an oligoarticular process, less than 5 joints, and progresses to polyarticular involvement. Has a predilection for the small joints of the hand and feet. Joints are usually swollen and warm. Morning stiffness is a prominent feature. Greater than 60 minutes of morning stiffness, patient minimizes, and some patients have difficulty answering the questions because they are stiff all the day. How long does it take for you are going to be? So it is more than 1 hour usually. Inflammation fluid increases in and around the joint as the patient gets moving and the fluid gets reabsorbed. The stiffness can occur after the rest. Other constitutional features include fever, weight loss, anorexia, fatigue very common, sleep disturbances very common, musculoskeletal reasons, neurological reasons, psychological reasons, worry about the illness, finances, job, family, etc. Functional status in rheumatoid clinic, we use health assessment questionnaire like dressing, bathing, grooming, cooking, cleaning, shopping, mobility, work, social attractiveness, and rank the functional status mild, moderate, and severe. The stiffness usually is insidious in onset, adds joints over time, has a predilection for small joints of the hand and feet. Joints become warm and swollen but not red. Morning stiffness is greater than 1 hour and the patient can often be tired and do not sleep properly, can result in significant disability very quickly. Extra-articular manifestations include xerophthalmia, which is dry eye, Xerostomia, which is dry mouth, Raynaud's phenomenon, carpal tunnel syndrome, pleural effusion, rheumatoid nodule, rheumatoid vasculitis. Zika features are xerostomia and xerophthalmia, Raynaud's phenomena, neuropathy, carpal tunnel syndrome, rheumatoid nodules, pleural effusion, and rheumatoid vasculitis. Investigations include the lab diagnosis and radiological diagnosis. The lab diagnosis, rheumatoid factor, presence of anti-CCP antibodies is more specific than rheumatoid factor. Increased ESR may also be seen. Anemia of chronic disease is common. Synovial disease, synovial fluid aspirate, show turbid fluid, decrease viscosity, and can increase WBC count. Renal functions, creatinine, urinalysis, liver enzymes, AST, ALT, ALP, hepatitis B and C, and baseline chest. Antibodies commonly tested are rheumatoid factor and anti-nuclear antibodies. Rheumatoid factors are positive in rheumatic disease like Sjogren's disease, rheumatoid arthritis, SLE, MCTD, myositis, and cryoglobulinemia. Non-rheumatic diseases include normal aging, infection, hepatitis B and C, SBE, TB, HIV, sarcoidosis, idiopathic pulmonary fibrosis. Rheumatoid factor in rheumatoid arthritis is asymptomatic. People with positive rheumatoid factor are likely to develop a rheumatoid arthritis. The higher the value, the greater the likelihood of rheumatoid disease. Useful for prognosis, patients who are RF positive are more likely to have aggressive disease. Not useful to follow titers, not predictive of flare-up, no predictive improvement. Radiographic findings. Radiographs early soft tissue swelling with juxta-articular demineralization, late symmetrical joint space narrowing with erosions. Rheumatoid synovium is a non-suppurative inflammatory infiltrate of the synovium due to aggregation of the lymphocytes and plasma cells. Principles of management. 90% of the joints involved in rheumatoid arthritis are affected within first year, so early treatment is required. Disability in early rheumatoid arthritis, inflammation, swollen, stiffness, and sore and warm. There is fatigue and potentially reversible. Most of the disability in rheumatoid arthritis results from initial burden of disease. People get disabled because of inadequate control, lack of response, compliance, and goal control and disease only. Joint damages occur early. 93% of the patients with less than 2 years of disease have radiographic abnormalities. Rate of radiographic progression is higher in first 2 years of disease. Disability occurs early. 50% out of the work at 10 years. Increased mortality with severe disease. Early treatment has long-term beneficial effects. A window of opportunity delay of 4 months can have long-term effects. Disability in late RA, too late, damage, fatigue, non-reversible damage could be bones, cartilage, ligaments, and other structures. DMARDs, disease-modifying anti-rheumatoid drug, reduces the inflammation, improve pain, and improve function, have been shown to reduce the radiographic progression and erosion. NSAIDs can decrease the discontinuation following the successful treatment with DMARDs. DMARDs should be started early and include methotrexate, and the best initial DMARD to start with is dihydrochloroquine, sulfasalazine. Second line is TNF inhibitors, rituximab, anti-CD20, and leflunomide. Common DMRD combinations is triple therapy of methotrexate, sulfasalazine, and hydrochloroquine. Double therapy with methotrexate or either leflunomide, sulfasalazine, hydrochloroquine gold, or sulfasalazine and pelequinol. TNF is a potent inflammatory cytokine. TNF is produced mainly by macrophages and monocytes. TNF is a major contributor to the inflammatory and destructive changes that occur in RA. Blockade of TNF results in reduction of a number of other pro-inflammatory cytokines, interleukin 1, 6, and 8. Infliximab and adalimumab is a chimeric monoclonal antibody directed against TNF alpha. Adanercept is a two-soluble P75 receptor attached to Fc portion of IgG molecule. Monoclonal antibodies to TNF, infliximab, adalimumab, soluble receptor, decoy for TNF, etanercept, receptor antagonist to IL-1, anakinra, monoclonal antibodies to prevent T-cell signaling, abatacept, and monoclonal antibody to CD20, rituximab. Infection could be common bacterial, opportunistic, TB, histo, demyelinating disorders, malignancy, worsening CHF, and blood count. Differential diagnosis include inflammatory polyarthritis, infection, rheumatoid arthritis, seronegative arthritis, connective tissue disease, SLE, ECT, associated with another systemic disease. Rheumatoid arthritis is a chronic, potentially debilitating illness. Early treatment can have a profound effect on this disease, and treatment is multidisciplinary. Thank you.